Hi, everybody. For week 6 clinical conference, I saw a patient, JL, who was an 18-year-old male with a past psychiatric history of ADHD, oppositional defiance disorder, reactive attachment disorder, anxiety, and depression, as well as substance abuse, who presented after a suicide attempt on February 10th by way of quercetin overdose. He was found unresponsive in the snow outside of the homeless shelter where he currently resides. On assessment, the patient was lying in bed, dressed in a hospital gown, and appeared unkempt. He appeared sedated with his eyes in a half open orientation during our interview. He currently denied any suicidal ideations and was adamant that his overdose was not an actual suicide attempt to end his life, but rather an attempt to what he said was to get high. He was cooperative to the plan for the inpatient psychiatric admission that he will have once he is medically cleared. So, in discussion with his parents, JT texts his father to inform him that he was ingesting quercetin with the intent to commit suicide. And he actually texts his father as he was doing that, and that was on February 10th. So, in the process of him taking the medications, he texts his father to let him know. His father then called the police, and he was brought into the MOD emergency room by EMS. His father described JS as having very manipulative behaviors in the past, and he has had a lot of antisocial behaviors in the past, such as stealing his parents' car, their money. He's been incarcerated 5 times, and he's also been prosecuted with credit card theft. His father and his mother decided that JL had to leave the home once he turned 18 and was of age, because he felt that their destructive behavior they just hadn't met the end of their rope with all of his destructive behavior, and also his inability to comply with all of the previous treatments and psychiatric recommendations. And also, to compound his psychosocial recent homelessness, JL was engaged with a clandestine relationship that recently ended. And I just wanted to point out too that in talking with his parents paid out of pocket for all of his previous psychiatric treatments, and that he had been to wilderness therapy twice, which is a very expensive treatment plan out of state, as well as multiple other psychiatric admissions. And he's also been jailed for extensive amounts of times, over 5 times. So I can kind of understand why they were feeling fed up with the patient's behaviors. All right, so for his diagnosis, Access 1 is major depression, Access 2 was deferred, Access 3 is acute delirium related to his overdose, and Access 4 was a recent breakup with his girlfriend and also being homeless, and Access 5 is 30. So for an article, I found a recent study that looked at oppositional defiance disorder, and it said that the diagnosis of ODD increased suicidality, as demonstrated by a recent research article. The author explained that of 925 children and adolescents with primary diagnosis of ADHD, 84% of the participants attempted suicide. So children who had ADHD and a co-occurring diagnosis of oppositional defiance disorder had attempted suicide in the past. The author says that all children with adolescents and children with ADHD should be screened for suicide ideations and attempts, as well as co-occurring ODD and sadness. And we should do what we need to do in order to prevent their suicide attempts and to help their overall psychiatric presentation. Okay, thank you. Let me know if you have any questions.